Welcome to this Coaching Corner in February 2023. It's good to be back after a bit of a break over summer. We're going to be discussing ultrasound of foreign bodies tonight. So I'm your host, Suean. If you haven't already subscribed to our YouTube channel where we host some of these videos, please do so. And for all the ultrasound educators out there, feel free to sign up to our Facebook community, the POCUS Educator and Seed Support Network. I want to let you know that this session is being recorded and it'll be available on our website in the next few days, along with all our previous episodes of the Coaching Corner. And you can find that under the resources tab on the homepage at ultrasoundtraining.com.au. Feel free to ask me questions, or if you'd rather ask questions offline, we can hold that to the end and turn off the recording and we can come back to them. So without further ado, we're going to look at ultrasound assessment of foreign bodies. So retained foreign bodies are a common and frequently complicated presentation in both the emergency department as well as GP clinics. And whilst retained foreign bodies are usually quite superficial, they can be missed very easily, even when a well-trained clinician performs a thorough history and physical exam. If you don't find them, they can lead to inflammation, delayed healing, and damage to the surrounding tissues. Organic objects such as thorns, splinters, and spines, things like that, can cause severe inflammation, hypersensitivity reactions, and even infections which are resistant to antibiotic treatment and require surgical removal as the only definitive treatment. Most soft tissue foreign bodies are involuntary, resulting from accidental injury, but special consideration is also necessary for those psychiatric patients who may purposefully insert foreign bodies into soft tissue. So metals, splinters from wood, and glass foreign bodies are the most common, and they're most commonly found in the hand, the wrist, or the finger. X-ray will demonstrate foreign bodies only if there's a difference in the densities between the foreign body and the surrounding soft tissue, and only if that difference in densities is sufficiently high enough to make it possible. So metal foreign bodies show up really, really well and are nearly universally detected on X-ray. But wood foreign bodies, the difference between the density is often too small to be appreciated on an X-ray. So in this case, ultrasound is the preferred imaging modality for superficial foreign bodies because of its ease of use, the low cost, and the lack of ionizing radiation. And the other great thing about using ultrasound is that you can use it to help you remove the foreign body as well. So ultrasound's useful, but how big is big enough for us to be able to see the foreign body? The ability to see the foreign body largely depends on your equipment and the frequency of the probe you're using. So you need a high frequency linear probe. Sometimes some of the older machines, the image quality is just not there. And it will also depend on the skill of the operator. So I've just been discussing with a sonographer colleague tonight. She was looking at a foreign body and she said, I knew something was there, but it took me ages to find it. She did 11 minutes of scanning to find this foreign body. And only when she ramped up on the fancy machines, when she ramped up the special imaging parameters that they've got, was she able to see it. So it does depend on your equipment as well as your skill. A study by Jacobson and his colleagues reported that they could reliably detect foreign bodies as small as 5 millimeters. And a study by Shields and his colleagues said that ultrasound had an overall accuracy of about 92% for documenting foreign bodies as small as 2.5 millimeters. Now, bear in mind objects that are quite deep in the tissue. So if they're more than 2 or 3 centimeters in the tissue, it's going to be more difficult to image them because the depth comes at the cost of decreased resolution. So we're going to walk through now a 5-step process for how to scan for foreign bodies. The first thing we're going to do is take a good clinical history. We want to prepare for the scan. We're going to conduct the scan. How do you measure them? And then how do we go about marking the spot with an X, or X marks the spot? So the first most obvious thing is to take a really good clinical history. Now, it's really important. course, because it helps narrow down the location to search, but it also gives us an indication of what the foreign body might look like on ultrasound. It's important to understand how long the foreign body's been in situ and how it entered or what was the mechanism of injury. Sometimes foreign bodies can migrate a little way from the entry site. So if it's been there for a little while and still bothering them, we do need to extend our search past the entry site. It's also handy to ask your patients whether they've attempted to remove it, how many times and when. Recent attempts at removal can sometimes, macerate the tissue a little bit and introduce air into the wound, which makes it harder for us to see the foreign body. And the other thing to notice is, how long has it been there? Is there any redness or swelling around the foreign body? Because often we can use this to help us locate the foreign body, and it works to our advantage. Now, the next step we're going to do is to prepare for the scan. We're going to remember the 3 Ps. So we're going to pop the patient details into the ultrasound system. We're going to choose the right probe for the job, and we're going to choose the right preset. Now, when we're talking about ultrasound probes here, you need to use a linear probe. And if you have the fortune of having different linear probes to choose from, use the highest frequency linear probe that you can, because we'll get better resolution near the skin surface. And the other thing to think about here is the size of the footprint. If I'm scanning a finger and I have a hockey stick probe available, as indicated over here on the left, I'd rather use the hockey stick because it's much easier to hold and to maneuver around a tiny little surface area. Sometimes, though, you don't have a choice, so you just have to use what you've got in front of you. Here's an example of a couple of images of the same finger, but taken with 2 different probes on the same machine and exactly the same settings. The probe on the left is a linear probe that has a 38mm footprint, and the frequency is 10 to 5 megahertz. The probe on the right is a linear probe with a 50mm footprint, and the frequency range is 15 to 6 megahertz. Now you can see the difference here in the amount of surface area that we can see in one image. So the image on the left, we just get the distal phalanx, and the image on the right, we kind of get the distal and middle phalanx worth of tissue. But the other thing here on this image on the right, you can notice the detail of the structures in the finger here, and we're starting to see the details of the tendon. Over here, we can see a couple of digital arteries. So the higher frequency probe here gives us much better resolution of the soft tissue, particularly near the skin surface. Often when we're scanning for foreign bodies, we need to use an ultrasound standoff. Because they're very superficial, it's helpful to use a standoff to help our imaging process, because the near field zone of the transducer is often not the best bit and the best resolution. The purpose of the standoff is to act like a spacer between the probe and the region of interest, and to increase our depth to the foreign body in the image. The other advantage of this is that by increasing our depth for many of the point of care systems, you can't adjust your focus. So by increasing your depth a little bit, you're now bringing your into the optimum focal zone of your machine. This is really important for very small foreign bodies. And you can see here a number of different versions of a standoff. You can either use a very thick layer of viscous ultrasound gel. They do manufacture standoff pads. Here's a homemade one where we've just filled up a glove with water, and also a water bath, which is my favorite. But we'll talk about the advantages and disadvantages of each of these in turn. So the first method is to use a very thick layer of viscous gel and pile it on the skin. Now that sometimes is enough to be able to help you see the superficial tissues. The trick here is, though, that you need to place the probe on the gel without dispersing the gel. So if you push too hard, you're going to make contact with the skin. So you need to try to have very good probe control, and you're just balancing the probe on the top of that layer of gel. Now, this is really dependent on the type of gel you've got. Some of the gel that's available is like putting on water, or maybe a little bit better than water, but it's really very runny and it just slides off this patient straight away. So that's not going to help at all. So there's a couple of really good types of gel that you can do this with, and you just pile it up, pop your probe on the top. Now, one of the problems with gel, though, is that there is the potential, if you have an open wound, that you can introduce infection into the tissue. So if they have an open wound, it's a good idea to use sterile gel. The other thing with this is if your patient's really quite tender, sometimes the pressure here can be a little bit sore for them when you put the probe on. It's possible to purchase manufactured gel pads like these. They can sometimes be a little bit hard to come by, and there's only a few people that manufacture them. Because of the nature of foreign bodies, these gel pads are created as disposable items, so it can get quite expensive as well. And even with these gel pads, you do need to put a little bit of gel on the skin, then the gel pad, and a bit of gel on the top of the gel pad. The other thing to note with these manufactured gel pads is that they come with the shelf life, as we discovered. And after a little while, if you exceed their expiration date, they tend to dry up and become hard lumps of agar gel. So you do need to make sure that they are within their use-by date. Now, another really handy trick is to use a glove filled with water as a standoff, and you can easily make this with the gloves in your department. So just fill the glove up with water, and again, it's important to just let the water trickle in so that you don't have too much air in the water. And then you need to tie the glove in a knot at the top. But the trick here is that you're trying to tie the glove in a knot without having a big air bubble in the glove. What happens is when you turn that glove on its side to use it as the standoff pad, the air bubble will rise to the top and will interfere with our imaging. So you can see on this image here, I'll get my video to start. You thought it was a video, it's not. You can see on the image here, we've got a big band of water in front of it. And so what happens is it gives us exquisite detail here of the skin surface and the tissues underneath. As I was pointing out before, this zone up here in the transducer is not the best resolution in our image. And so typically with a lot of the point of care ultrasound machines, their focal zone is optimized at this sort of area, 50 to 75% or 50 to 75% of the way down the image. And so if we can use the gel standoff, that means that our finger is deeper in the image, and now our finger is sitting within the focal zone. Now, to prepare the gel, you find a glove, fill it up with water. Just for your information, it's much easier with a larger glove because you've got more of the wrist of the glove to tie a knot in it, as I found out by trial and error making this talk. I'm going to put some gel on the patient's region of interest, and then I'll place the water-filled glove on top of the gel. Then we're putting gel on the top of the glove, and then we're scanning. Now, the purpose of all these layers of gel is that we need to eliminate air gaps along the pathway from the ultrasound probe to the region of interest. So this technique does work quite well, but of course you need to be careful. If the patient is really tender, we've got a bit of weight sitting on their hand, so they might not tolerate it so well. My favorite or my preferred method is to use a water bath technique. And all you do here is fill up a big plastic bowl full of water, and then you dip the head of the transducer into the water. Now, the water bath technique is especially useful for areas that are painful to touch because it doesn't require direct pressure from the probe on the skin. Now, I also use this if someone's got an open wound and I'm testing for tendon integrity, if they've had a chainsaw accident or something like that. But if they've cut their hand or their finger, it's easy for a patient to rest their hand in a plain bath of water. And it also helps to keep infection down as well. Now, the trick here is that you a big plastic bowl, and it needs to be big enough so that the patient can immerse their hand or their foot into the bowl without it being at a funny angle and coming out of the water. And we want to use a plastic bowl rather than a metallic bowl. If we use a metal bowl, the sound will just bounce back off the bottom of the bowl and will interfere with the image. The trick with the probe too, you can dip the head of the probe in, as you can see here, up to just beyond the probe marker there. You don't want to dip it in and make sure that you haven't got the probe relief and the cord in the water. So you do need to be a little bit careful. The advantage of this technique here, as you can see, we're looking at a nail bed, and you can actually see the fingernail here and where it kind of hangs over a little bit. Maybe need to cut their nails. You can also see really good detail of the skin, and because we're not squashing the tissue, we see the superficial tissue really nicely. It's really important as you fill the bowl to remember that our taps are mostly really aerated now. So if I turn the tap on full to fill the bucket up quickly, I'm going to get lots and lots of air bubbles in my water. And you can see them just floating around. These little white echogenic flecks here are the air bubbles floating in the water. So to get around this, you either need to fill the bowl up very slowly and just have very low trickle of water, or you fill the bucket up quickly and then set it aside for 10 minutes or so. Now, the air bubbles that you see in this video, also in this video here, that they were there after the water had been sitting for about 5 minutes. So you probably need to leave it a little longer than that to make sure those air bubbles disperse. Now, having a look at some images where a water bath has been used, you can see here this foreign body entering the finger, and we can see the skin really nicely across the top. Now, this image on the right doesn't have a foreign body, but I put it in to show you that ordinarily you would not see these vessels in the finger because they're usually too small. And if we put the probe on the skin, the weight of the probe itself will compress these vessels. So it's really, really handy with the water bath technique because you don't have to touch the patient. It doesn't cause pain. You can get the depth that you need so that you've got your region of interest in the focal zone, and we get really lovely detail. So if we look at and compare images from no gel, so this is using no standoff pad, and this is all the same nail bed. So we can kind of see that there's a finger there and we can see the bones okay, but the soft tissue hasn't got very good detail. Here's where we're using a gel standoff pad. And again, that can work. So we've just put a big blob of viscous gel on the finger. Sometimes there can be little air gaps and stuff in amongst that blob of gel, so it can be a little distracting. But the best pictures that we have here is with the water bath technique, and you can see the actual nail bed itself. In comparing the three images on looking at the finger pad side, this is with no gel. We have the gel here, and there's some air bubbles in that proximal bit. Now, the disadvantage here is that we can't pile the gel up high enough to get the finger here at the optimum focal zone, which is sitting around 50% to 3/4 of the way down the field of view. So the water bath technique lets us get that correct depth so that we get better detail of the skin and of the soft tissue. The other thing to have standing by is a permanent marker pen. Because at the end, when you've found your foreign body, you need to mark on the skin where it is so that you can go about retrieving that foreign body. Now that leads us on to how we go about scanning for foreign bodies. The first tip that I give you is to make sure that you also are in a really comfortable position. I recommend that you sit down where possible and adjust the bed height so that your forearm and your elbow, if possible, are supported. Now, what that does is it means that your probe is in your fingertips. You have maximum control over the probe, but it also helps you be really light with your touch and to sort of hover your probe over the affected area. Now, you're going to get messy. There's going to be gel everywhere, but if you haven't got gel on your hands, you're not doing it right. If you're worried about the gel, just use a glove. Now, the other thing about this positioning, it means that you can hover that probe and you don't squish the gel away and you don't make contact so much with the skin. The first thing that you do when you're scanning the region of interest for a foreign body is to scan the area in both planes. We want to extend the scan past where the foreign body entry point was in both the longitudinal plane and the transverse scanning plane. Typically, we're looking for a hyperechoic or a white structure. Sometimes it's much easier to visualize a foreign body in one plane and not necessarily the other. And scanning it in two planes means that we build up a three-dimensional picture of the foreign body. Now, this lion, if you just looked at the picture on the right, you would think that she was eating her baby. But when we scan in the other plane, we can see that she's just holding the cub by its neck. And so that's the same sort of effect when we're scanning in ultrasound. We need to scan in both planes to build up a three-dimensional picture of the object. And where possible, you may try to scan from a different window as well. So try from different angles to see if you can see the foreign body better. Remember that when we have, well, particularly metal objects, but we see our objects best when we hit them at 90 degrees. So we need to try and get perpendicular to our foreign body. And sometimes that might be from a different angle as what the entry wound is. By scanning in the two planes, we build up this three-dimensional picture and we can work out what shape the foreign body is. The other thing we need to do is to survey those surrounding structures to see if there's any vessels or any other anatomy that are affected. Vessels in close proximity to the object may prompt you to avoid probing the area, or it can guide you in planning your surgical removal of the foreign body. In this image, we can see a hyperechoic foreign body here, and it's coming very, very close to the tendon. And it may even be interfering with the paratenon here. This patient complained of right hand pain after she got a large fragment of wooden cooking spoon that penetrated her right palm approximately a week ago. She reported immediately removing the splinter, but was prompted to go to the emergency department after her pain gradually increased. And she also noticed that her ability to flex and extend her fourth finger was starting to be affected. The splinter here indicated on the image is very, very close to the tendon. And so the swelling from the body's inflammatory response will be having an impact on the tendon. And there may also be some of the splinter touching the fibers of that tendon. So this case is a really good example of why we need to focus not just on the foreign body, but we need to survey the surrounding structures as well. We need to figure out, is there an effect on any of those surrounding structures? And also, how are we going to remove this foreign body without further injury? Here's an example of where we scan the surrounding structures and we can see a big hypoechoic area that actually helps us to see the foreign body. So this hypoechoic area is purulent material that actually makes like a halo or a window because it's water-like. It makes a window so that we can see the foreign body better. This is a case of a 35-year-old male patient who presented to the emergency department with left foot pain and swelling. He'd sustained a puncture wound with a large wooden splinter to the lateral aspect of the dorsum of his foot a week ago. He believed he'd removed the entire splinter, but over the next week, the site became increasingly red and tender and swollen, and there was no ooze from the wound. So X-rays demonstrated that there was nothing there and were useless, really. They showed no foreign body at all. And so point-of-care ultrasound was done, and they demonstrated this foreign body really quite nicely. And as I said, the surrounding structures here, or the body's inflammatory response, actually made for a good window to assist in the visualization of this foreign body. Here's another example of a collection around the foreign body that sort of helps us to see and helps us to visualize the foreign body. So now let's look at some common sonographic signatures of commonly reported foreign bodies. So mostly they will be glass, metal, or splinters from wood. And as I mentioned at the beginning, the most common location is the wrist, the hand, and the finger. The sonographic appearances of the foreign body depend on the acoustic properties of the material of the foreign body. And typically there'll be a hyperechoic area with variable shadowing and reverberation. So after finding the foreign body, clues to the material can be gained from the acoustic details. So is it really, really bright white? And is there a reverberation echo like we have with metal here? So here's a metal object, and you can see the reverberation echoes behind it. This is glass. So glass tends to be quite white and it has sort of indistinct shadowing behind it. They can be quite variable in size. And so those little tiny shards of glass that you get in your foot when you break a glass and stand on the leftovers, they can be really, really difficult to see. And sometimes it's easier to wait a couple of days so that the body's inflammatory response actually makes that halo around it, makes them more visible. Just because you've scanned them once, it might be that if you come back in a couple of days, you might be able to see a foreign body that wasn't necessarily visible before. And this last image here is a picture of a wooden splinter. And so we've got the bright white interface here and quite a distinct shadow behind it. Here's an example of using the artifacts to demonstrate where the foreign body is. So, you know, perhaps the foreign body itself blends in with the surrounding tissue, but what actually stands out more here is the shadowing behind it. And that's often your first clue to finding the foreign body. Here's an example of a little BB bullet that was found in someone's neck, unfortunately. So you've got this bright white dot here, but again, the BB bullet itself kind of blends into the tissue, but the artifact that it creates, this very linear artifact through the image, the comet tail artifact, you can see that much more readily than the actual bullet itself. Here's that wooden splinter again, and the splinter that was pulled out. So you can see it correlates in about the same size, but it's also very smooth on its edges and creates that very distinct posterior acoustic shadow. Now, organic objects can be really, really tricky. This is an example of a bee stinger in someone's finger. They had an X-ray, and if you really squint, you can kind of see in hindsight, after you can locate it on the ultrasound, if you go back to the X-ray, you can kind of see a tiny, tiny little fleck there. But ultrasound in this case proved far superior because the body's inflammatory response made that nice hypoechoic halo around it and a little collection around it, which allowed us to see the foreign body much more clearly. Here's a bit of a graphite pencil in someone's foot. So you can see it on a very underexposed X-ray. So sometimes if you did a normal exposure to look at the bones, you wouldn't be able to see this because this would be all blacked out. But they've done a soft tissue exposure on this X-ray, and so you can start to see the outline of it. But again, on the ultrasound, it was much, much more clear because we've got this very distinct linear line with a distinct shadow behind it. Needles or metal fragments are often the most easiest foreign bodies to see. Now, the thing is here is that you can see them on X-ray as well. And what we're looking for on the ultrasound is that reverberation echo behind it. Here's an example of a broken needle tip that was found in someone's knee. And I think this case really adequately demonstrates the importance of getting two different views. When we look at the AP X-ray here, it looks like this needle is embedded in the femur. And when we look at the lateral X-ray, it looks like this needle is embedded in the patella. Now, when we did the ultrasound, we could see nothing of a sort. And we can see over here the very bright tip and a little bit of a comet tail artifact behind it, and the patella sitting just here. But we can also in longitudinal see the length with the reverberation artifact quite nicely. Now, the challenge here with a needle like this is very, very thin. And so it takes really, really good probe skills to be able to lengthen it out and demonstrate it like this and show that reverberation artifact. And the key thing here is to keep the probe in between your fingertips and use a pivot action. So you anchor one end of the probe, swing the other end of the probe to lengthen that out. Here's some examples of glass, and now these are really, this is only a couple of millimeters, but you've got this bright echo here, a little bit of a shadow. And again, here it's a little bit indistinct and it is an older picture, but again, the shadow behind it is what gives the location of this foreign body away. Here's an example of a thorn and a prawn. So they look very, very similar. This illustrates the importance of taking a really good clinical history. So you can see here the very spiky nature of the thorn, and here we've got a prawn, or the prawn claw. Now, after we've done our very thorough search for the foreign body, and look, sometimes that can take a little while, as I mentioned. You can go over the area a number of times, try a couple of different angles. It can be really tricky to find them, but it's really important that you use a very systematic and thorough technique and do a crisscross pattern to try to cover the area in both planes. And once you've found the foreign body, the next step is to do some measurements. So what we need to establish is the length, the width, and the height of the foreign body. So we'll take a length and a width, if we can, in the longitudinal plane, and a height measurement, a length and a height in the longitudinal plane, and a width measurement in the transverse plane. The next thing we're going to measure is the depth from the skin surface to the target. So this will give us an idea of how deep in it is, and if you're going for a surgical removal, you'll know how far you need to cut down on it. So here's an example of an imaging series that documents the foreign body and the measurements that we need to take. So we have a length measurement here, we have the width measurement, we have a measurement here of the collection around the foreign body, and here we have a measurement from the skin surface on one end and on the other, so that we know how deep it is in the tissue. And another example, this is the thorn in the thumb. So a lady reached into the freezer to get something out. Now she'd put her old prawn carcasses, she'd peeled them, she'd put them in the freezer so they didn't stink up the kitchen and the bin. And so she put them in the freezer and reached in to grab something else and felt a sharp scratch on her finger. Now, she didn't think anything of it for a couple of days, but it was still bothering her. So she was one of our staff members, so we quickly had a look at her finger using the water bath technique, and we found a prawn claw. So off she went to the GP to have this removed, and although it's a blurry shot, I think it was taken without glasses, you can see the prawn claw here. So we measured the length of the prawn claw, the width of it, the depth from the skin surface to the edge of it. And so then she could go to the GP and have that cut down. We could report that it was, 3 millimeters underneath the skin surface, and you're looking for an object that's at least this big. So once we've measured that for an object and we know where it is and we can geolocate it, now we need to do an X marks the spot to figure out how, if you are going to do a surgical procedure, you can cut down on it. So the way I go about doing this is I find the longitudinal axis of my foreign body, and I pop the probe on like this, and I use the texta pen to mark at each end of the probe. I then find the foreign body in transverse, and I take care each time here, I want the foreign body to be right in the middle of my screen. And so then I pop the probe on in transverse and I mark the end of my probe again. Now, what that leaves me with is markings on the skin like this. Now, you might need to wipe off some of the gel so that your marker pen will actually make a mark on the skin. The other thing I have done too is use the end, not the sharp end of the needle, but the other end that attaches to the syringe. And I just dig that into the skin a little bit to leave an indent on the skin, because that will outlast while you wipe the gel off the patient, and that allows you to then go in and mark where you put those, where those indents on the skin are. So once I've got this sort of geolocated, I then join the dots, and that means that my foreign body should be right under the X marks the spot here. But rescan again and check to be sure. It's much easier to sort it out, wipe off the gel and reposition it here than it is to be cutting down on the wrong spot and fishing around forever. So that's kind of how we go about doing the scan and marking the spot. But obviously there are some pitfalls associated with foreign body scanning. The first one is it depends on the size of the foreign body. So smaller foreign bodies can be really, really difficult to see. It depends what they're made of too, and how much of a shadow that or an artifact they create. So some of the very small foreign bodies are just not big enough to interfere with the ultrasound beam. So, you know, those tiny little flecks of glass, they can often be very, very difficult. Foreign bodies that are deeper than 2 or 3 centimeters in the skin can sometimes be really, really tricky to find because the resolution is not so great. If you have air in the wound, so if your patient has been trying to get the foreign body out and they've been digging around for a while, they can have air in the wound. And it can also macerate the tissue a little bit. And so it makes it a little bit irregular on the ultrasound and harder for us to see what's foreign body versus macerated tissue. And the other thing is that you need to have a really good knowledge of the surrounding regional anatomy. You want to make sure if you find a foreign body that there's no arteries that you're accidentally going to cut down on or any tendons that get in the way. Or if you're removing them, if they are coming out of tendons, it might affect your post-care management plan for how to deal with this afterwards. So it's really important to know what the surrounding tissue is as well. So that's my 5-step guide to how to scan foreign bodies. So in summary, we've looked at the importance of taking a really good clinical history. If we know what the foreign body is, we've got a better idea what sort of artifact to look for. If we know where it entered, how long it's been there, are we expecting a pus collection or an infective collection around it, that can all help us to find the foreign body. We need to prepare for the scan. So this is just getting our equipment, ourselves all set up, and getting our water bath or the gel, the glove filled with water, all of our extra equipment ready. So you're going to start by choosing the right probe for the job, put the patient details in, and then choose the right preset on your machine. You can use a gel, really viscous gel, and pile it up on the skin. You could fill a glove up with water. You could buy those specifically made standoff pads, or you can use a big plastic bucket and a generous size plastic bucket so that you can put the hand or the foot in the water. When we scan for the foreign body, we need to extend the scan past the boundaries of where we're expecting the foreign body to be so that we can see any effect on surrounding tissues, but also to make sure that the foreign body hasn't migrated, and to give us an idea of what the echo texture of the surrounding tissue is like, so that when you see a foreign body, it stands out. The next thing we're going to do is measure. We need to end up with the length of the foreign body and a width, and if it's a big chunky one, the height of the foreign body. We also want to measure the depth from the skin surface to the foreign body so we know how deep it is in the tissue if you're surgically removing it. And last but not least, we've gone through the technique to mark the spot with a big X so that you can go back later and cut down and find this to retrieve the foreign body. So, does anyone have any questions?
I've got a couple of questions, Suean.
Go for it, Alan.
Obviously, when you're using the water bath or the standoff pads, that's more a diagnostic technique because it's going to be very difficult to be trying to procedurally remove it with those things in place. So are you making an assumption, probably realistically a lot of the time, but not all the time, that if you can see it with the water bath, that you'll still be able to see it without the water bath and some gel, because at some stage that's what you're going to have to do to be able to remove it. And you obviously can't mark it while it's in the water bath. So is that what you're hoping, that you've managed to see it with the water bath or the standoff pad, and then with your eye in and you know where it is, that you're expecting you'll be able to just see it with a blob of gel?
Yeah, look, the other thing that I do have on hand is I don't know if you can see it. Yeah, there we are. You can, an empty pen canister, because you can put the hand in the water bath and you just dig this in like that and just drill it into the skin on each end of the probe. And then you end up with an indent. I don't know if you can see that. I've got a bit of an indent here. And so that takes away the, like, you can't mark it underwater. You've just got to find it first. And then I can use this remotely to sort of mark the skin, bring the hand out or the foot out, dry it off, and then mark it with the texter in the sort of the two planes. Then I got an X marks the spot with a permanent pen, and I can scan it again. You can then look and see if you can see it. You'll get an idea. If the foreign body is really small, it might be really difficult, but a sort of more generous foreign body, you're probably going to get away with the big gel standoff pad once you know where you're looking for it. And the thing is once you've created that X marks the spot, it's easier to find it again too.
Yeah. And I suppose the other question is, even though I'm a X marks the spot assisted static type of person, they all mean the same thing, and I'm not so much a younger generation, real-time dynamic guided technique type of person. There are people who will prefer to remove the foreign body as a real-time technique. So obviously that's not that amenable to a water bath or a standoff technique. And I suppose the other thing about the X marks the spot is that unfortunately one of the things that can happen is the foreign body can be moving on you as you're trying to remove it. And I suppose that's where the real-time technique can add some value, because you can potentially follow it as it's moving. Yeah, I mean, I find them incredibly frustrating, but from, people who've done more than me, real time, and when they do try to do it as a real time technique, they tend to try to go down the same estimated path of the foreign body if they can see that or where it might have gone, and they try to dilate it up with some alligator forceps, the smallest that they can get, and really blunt dissect down what they think the pathway of the foreign body was and try and grab it from its end. But it is very challenging at all times.
I think that the alligator forceps technique would only work for some specific types of foreign bodies. So you might be able to real-time remove the prawn with alligator forceps, but you only get one or two goes with this, because it's so what you do is you advance the forceps, open them up, advance them a bit more, grab your foreign body and pull it out. Once you open those forceps, you macerate the tissue a little bit, and then it makes the foreign body really, really difficult to see. So,
and maybe let some air in the tract as well. And
you've got air as well. So if you had a tiny fleck of glass or something that's only a couple of mils, I think that's really difficult to go after with forceps and to do in real time, and potentially a cut down approach is probably better, and that way the depth from the skin surface and you've got your triangulation points. I remember seeing at a conference, I think it was William Shields, which is the article that I quoted right at the beginning. He told a story. Now, he's a radiologist that's had removed 800 or something foreign bodies, so was very good at doing ultrasound guided. But he told a story of a 3 or 4 year old kid that was on the back of a quad bike, and the older brother or sister took off, and this kid fell face first into a puddle of mud and got a foreign body or a bit of twig right down the eye here. And they could find it, and he ended up retrieving it under ultrasound guidance with just a tiny little crease that could blend in with the corner of the eye. So there was no sort of scarring that was relevant. But again, if that was the first foreign body that you were doing, that would be a scary proposition, I reckon. And you have to be careful about what the foreign body is. I remember someone with they'd been out on the Barrier Reef and they got a stinger or a stingray barb or something through their foot, and it's got little thorns the other way. So if you pull it out the same way it goes in, anyway, it just makes me shudder. But some of those things, it really depends what the foreign body is and if you can advance the forceps to grab it, to pull it out. If it's, and this is where the clinical history comes in, if it's organic material, it can break down quite easily as well.
Disintegrate on you. Yeah.
So needles and metallic things are probably easier, but those sort of organic stuff is going to be quite tricky.
Yeah, and there was something else I was going to say. Sorry, I just had a blank, but it might come back to me. I'll see if anyone else has any questions, and then I'll
So,
come back.
does anyone else have any questions? I'm just going to check the chat box here.
Yeah, I remember what my question was. I think clinical judgment is also when not to try to remove it, as in, particularly if it's small, because just because there's a foreign body there doesn't mean everything needs to come out, you know. I mean, if something's just a couple of millimeters, often, you know, you have a bit of a discussion with a patient and say, look, you know, these sort of things sit in people's tissues all the time. I mean, I'm sure Suean and most of you have seen x-rays where you see these incidental findings of foreign bodies in tissues that have been there for God knows how long, because they've come in with some other injury that's not even related. And, you know, so just because you see a foreign body doesn't necessarily mean that everything has to come out. I think, you know, if I saw something was a couple of millimeters, whether it was glass or something else, and it's in there fairly deeply, I'm going to say, look, you know, maybe this is something we should just leave alone and see what happens. And maybe we put you on some antibiotics. But, you know, there's plenty of stories of people having bullets and stuff in their body, and people don't go and always pull everything out. So, you know, like I think you've got to use a bit of common sense and not try to get everything out, especially when it's small.
Yeah, it's a good point. Does anyone have any other cases or experiences that they've had that they'd like to share, or questions? Well, I'd like to thank you all for joining me tonight. It's great to see all your faces again on in the new year. If you've enjoyed this episode, feel free to look at the back catalogue, which, as I mentioned, is up on our website. Feel free to subscribe to our YouTube channel or share it with your friends so that they can also benefit from my tips and tricks. Otherwise, if anyone's got any ideas for next month's webinar, feel free to get in touch and let me know, and we'll see if we can make it happen. Thanks again, everyone, and I hope you all have a great night.